So I'm going to talk to you about opioids and alcohol. And just by way of brief introduction, I'm a family medicine trained, I'm a family physician, and I've had a focused practice in addiction medicine for the last 17 years. All right. I do have some industry disclosures from Indivior, which manufactures Suboxone, and Purdue Pharma, which of course we all know manufactures opioids. All right. So in terms of the objectives, so in 20 minutes or less, I'm going to talk about these things. I thought, how am I going to convince a bunch of cardiologists to care about opioids and alcohol? So I'm going to talk about the burden of disease for you. I guess like hypertension and hyperadiposity, to encourage you to think of these as the chronic relapsing conditions that they are. And I think, if there's one message that I'll have for you is that for substance use disorders, there seems to be this sort of therapeutic nihilism, right? Oh, we can't do anything, oh, it's hopeless. And I really want to challenge you on that, that like hypertension and hyperadiposity, these are treatable conditions, and some of them respond spectacularly well to the treatments that we have to offer. And the last message that I'll give you is that we have a substance use program at TOH now, and we are a resource to you. All right, so starting with alcohol. Cheers. Okay, so a little bit of interactivity. Which, in 2015, 2016, which caused more hospitalizations? MI or hospitalizations caused entirely by alcohol? Who votes for MIs? Nobody, because it's a loaded question. Yeah. So, in fact, according to the Canadian Centre on Substance Abuse, there were 77,000 hospitalizations entirely caused by alcohol, compared to 75,000 caused by MIs. So, pay attention, right? This is a thing. You want to know just some resources. Googling around, what am I going to talk to Heart Institute folks about? Chief Public Health Officer's report. The point with this slide is, we all get excited about tobacco here, right? Tobacco's bad, there's no, it's all bad, we gotta quit. But, the point of this slide is to show that alcohol is really, truly woven into the fabric of our social interactions. Most of us drink, and most of the time that is not a bad thing. The point is alcohol is socially normative, which makes it perhaps a little bit more challenging to talk about. Impact, right? Almost 2% of all mortality in Canada is caused by alcohol. Costs a lot of money. Impaired driving is bad. Drug-related hospitalizations, alcohol is the winner or the loser, right? It costs a lot. Okay, another question. Quiz. What risk factor is causing more disability-adjusted life years in Canada? High cholesterol or alcohol? Who votes for high cholesterol? You guys are ready. Who votes for alcohol? Yeah? Because, this website gave information sort of globally, but in Canada, so you got all the risk factors that we know and love. Tobacco is at the top, dietary, hyperadiposity, blah, blah, blah. Ooh, look, alcohol and drug use is number 6 above high total cholesterol in terms of causing the highest rates of death and disability combined in Canada. All right, and globally, I'm just going to not spend too much time. This is from The Lancet. It was a really cool paper about sort of what causes the most global burden. And, that's a terrible slide, but alcohol is number 3 up there among a bunch of other things. And it moved up. From 1990, it was number 6, and in 2010, it was number 3, and then it was number 1 in sort of young to moderately older adults. Okay, all right, next quiz. Is there a role for medical treatment of alcohol use disorder? Is this in our wheelhouse? What do you think? I mean, medically, can you treat this? True? Yeah, true? Yeah, false? No, you don't think so? Because Bob Dent just mentioned Naltrexone, which is, now it's going to be your favorite drug. Next quiz. What is the NNT for Naltrexone to have a clinically significant effect? Just give me some numbers.
10.
10? Anyone else? Okay, Bob, did you see that? Who said that? You're pretty much correct. So the NNT is 9, and now this is not a spectacular cure, right? This is a chronic relapsing illness. So naltrexone reduced the risk of heavy drinking in about 83%. They have 1 less drinking day per month, and on average had 1 less drink per day on the days that they did drink. So, is that spectacular? No, it's not. But when you consider that, these small gains can actually be quite meaningful in people with alcohol use disorder, this means something. And guess what? Their GGT went down. Okay. Given that this is not a spectacular cure, but, given the burden of disease, it's a tool in our toolbox. All right, I'm going to spend a few moments talking to you guys about taking an alcohol history, because this is something that is easy to do. Yeah, who feels excellent taking an alcohol history? You guys like, yeah, awesome, fantastic. Okay, so common errors, right? Well, that you forget to ask, or like you accept answers that are not specific. Oh yeah, I drink socially, it's no problem. Okay, you write that down. And then I will, if you do a consult in my service, I will give you feedback on that. You gotta define what a drink is, right? Because people don't, when they pour at home, they don't sort of measure a number of mLs or ounces, right? They pour big glasses. And we miss binge consumption, right? If you ask about average consumption, you miss the folks who drink 10 drinks on one day. So how do you go about, how do you ask? You ask everybody, and the way I like to introduce it in a very non-confrontational, non-threatening way, you say, well, in a week or a month or a year, on how many occasions would you have any amount of alcohol, right? And so you get them talking. You'll catch the folks who have a half a glass of champagne on New Year's Eve. And, there's folks that, well, I don't know. In a week, how many days would you have a drink, right? So you just kind of, keep on asking. And you tell them what is one drink. You define it for them. I have a picture for you coming up. And then you ask, well, what's the most you would have had? Say in the last month or the last year, what's the most you would have had on one day? And you ask them that. And open-ended questions. Here's what a drink is. You define it in a bottle of wine. There are 5 standard drinks. And beer, you got to be careful because you go to Loblaws now and you walk down the alcohol section, and there are a lot of tall cans of beer, right? There are a lot of 500 mLs cans of beer. That's more than 1 standard drink. It used to be in the good old days, like the 340 bottles of beer, 5%. That's 1 drink. But now we have the craft beers. There's 6%, 6.5, and 500 mL. So you got to be mindful of that. You guys using the cage? I hate the cage. It's not very well validated. I'd stop using the cage. Binge drinking. If you have time for one question only, how many times in the past year have you had more than 5 drinks if you're a guy, or 4 drinks if you're a girl? That could be, yeah, some people are laughing because it's like, do not do this test on yourself right now. Okay, but the audit. Okay, this is really where this is very well validated. It's a little bit longer. It's 10 questions. There it is. And actually, the patients can self-report, right? They can self-fill in this questionnaire. But the thing about the audit is it's much more specific than any kind of screening tool that you can use. How often do you drink? How many do you have? How often do you have more than 6? How often does it happen that you can't stop? How often has it happened that you failed to do as expected to you because of your drinking? Eye opener and guilt and remorse, those questions are in there, so maybe the cage, don't completely throw out the baby with the bathwater. Have you had blackouts? Have you had injuries as a result of your alcohol use? Are there people concerned? I suppose that counts in the annoyed part of the cage. But this really gives you a lot more information if you do the audit. And score of 8 or more, it's like, okay, you want to pay attention. And the higher the score, the higher the risk of AUD, alcohol use disorder, and 20 or more, they probably have AUD. So consider looking that up. Pharmacologic treatment. So we put people, I remember a few years ago that depression was the big deal in cardiology, right? After people have had an MI, we got to screen for depression. It's predicts poor outcomes, and so everybody who had an MI got put on sertraline, it seemed. And I don't know, I mean, that was good, right? We should ask about these things. The effect of naltrexone on alcohol is probably about, similar to using antidepressants for depression, right? That's where we're at, and we do not hesitate to prescribe sertraline to folks with depression. So let's talk about naltrexone. So Bob already gave a great introduction to naltrexone. It's an opioid antagonist. And why does it work? Well, probably because some of the pleasurable effects of alcohol are mediated by the endogenous opioid system. So it just basically makes drinking a little bit less fun. And it works. We've heard about the side effects. Yeah, opioids don't work if you're on naltrexone. You can increase, starting to at 50, go up to 100, 150. It's nice to have baseline LFTs. I don't know, there's sort of, in practice, not everybody does baseline LFTs, but there's a 1 in 66 chance, I think, of LFT elevations beyond 3 times. So if they have risk factors for liver disease or pre-existing, it's probably prudent to monitor for that. Oh, the nice thing about naltrexone, they don't have to have already quit. They can just start it. And as time goes on, when it works, they'll just get less reinforcement from the alcohol use. And actually, two other things, little factoid, sort of trivial pursuit things about naltrexone. Likely, when we are in the age of pharmacogenomics, there's a certain genotype that seems to be where naltrexone is particularly effective. Maybe we can screen people one of these days and figure out, okay, you're going to respond to naltrexone, and you're not so much. So there's a really high genetic component, but we don't know who those folks are yet without testing them. And maybe you'll have heard of the Sinclair method, which is kind of the easy way to quit drinking, where you don't have to make any commitment to anything. Where the only commitment you need to make is to take a naltrexone the days that you intend to drink. That's all you need to do. And so there's the evidence is sort of mixed on that, but it's a way to get people's foot in the door. I got an e-consult. I get a few e-consults on that. Well, should I try this with my patient? Hey, meet them where they're at. If that's what they're prepared to do, there's no harm in that. Okay. Acamprosate. Anyone? You guys heard of Acamprosate? Few people. So this is a great tool. It's a general benefit. Both naltrexone and acamprosate are available on ODB with an LU code. Acamprosate, naltrexone is great for reducing drinking. Acamprosate is good for maintenance of abstinence. If they keep on drinking, maybe acamprosate isn't really working, but it sort of relieves those subacute withdrawal symptoms that are kind of caused by excess glutamate. Where alcohol use, it's you get this imbalance between GABA and glutamate, and you're stamping down the excitatory mechanisms, and so cessating of alcohol, you get this rebound of all this excitatory kind of neural activity, and acamprosate sort of helps to keep it sort of settled down. That's the way I conceive of acamprosate. 3 times a day, not the greatest for adherence, but it's a tool. The other tools, topiramate, which Bob talked about. Gabapentin has evidence, baclofen, and good old anabuse, disulfiram. It is still a thing. And there are patients where I have prescribed disulfiram with good effect. It works when you select the right patient. That's the patient was the right case. You have to go to a compounding pharmacy to get it, and it's not covered, but you can get it. All right. And what am I doing? Okay. Opioids. So we have an opioid epidemic. This is from the Globe and Mail a few months ago. People are dying of opioids. BC is hit very hard. They have a higher rate, though they classify all drug-related deaths. They don't exclude. This slide did not exclude opioids, but it's a wave that is moving east. It's you read the paper. There's an article about opioids almost every other day. Health Canada. So this slide is from Health Canada. Now, so the purple line is ED visits. So there's so 2000, 2013 is when Oxy Neo came on board. And then, you know, the last few years, fentanyl has sort of come on the picture. So you can see the mortality trends are going up, and ED visits are really spiking. Treatment of OUD. This is my favorite topic of all time, because this is what I do. This is what I've done since 2001. And, you know, I love it because you do see these spectacular successes that people's lives are really completely transformed when they are exposed to the right treatment. So that's what I love about my job. So which do you think is, which do you think is better for opioid use disorder treatment? You gotta get off those opioids and stay off, or we gotta keep you on opioids. So who votes for abstinence-based treatment? Nobody? Who votes for maintenance treatment? Okay, good, thank you. Well, again, that was a bit of a loaded question. All right, don't take my word for it. Look at National Opioid Use Disorder Guidelines. And, you know, these guidelines really, I mean, you know, unlike congenital heart disease, I think opioid use disorder treatment is actually very dead easy in many ways. There's not a lot of debate. The guidelines tell us what to do in most cases. There's two guidelines that came out, one national and one from BC. Okay, they recommend against abstinence-based treatment because there's such a term as death by rehab, that if someone goes to abstinence-based treatment for 28 days, they come out, I'm off, I'm clean, woohoo, you know, it's gonna be great. And then suddenly they have lost all their tolerance and they have a relapse, and the amounts that they're used to using are now lethal to them. The other scenario that happens, where that happens, can anyone guess? Incarceration, right? Someone goes to jail. You know, these folks go to jail a lot because guess what? Drug use is illegal, and so they run into a lot of criminal interaction with the criminal justice system because of their medical condition. And so they go to jail. It's hard. It's not impossible, but it's hard to get drugs in jail. Most of them, you know, they'll detox and they come out of jail. You know, I'm free, time to party, and they overdose. And that is actually really backed up by data. And now I'm just being a little bit indulgent. There's one kind of cohort of people that actually do very well in abstinence-based treatment for opioid use disorder. And can you guess what kind of group of people that is? Doctors! Thank you! Absolutely. Doctors with opioid use disorder do well in abstinence-based treatment. Why? Because, well, first of all, we have a lot of social assets. And actually, mostly that we get really super intensive treatment and that we are accountable. If we want to continue being doctors, we are accountable to the monitoring program. If in Ontario, if you're a physician who's presented into problems with an opioid use disorder or even any substance use disorder, in order to keep on being a doctor, you will be called for a urine drug screen 48 times in the first year of monitoring, right? So you got to pee in a cup once a week. So that's a real deterrent to relapse. So anyway, that's, and another little kind of factoid. There's an argument that all people with substance use disorder should get that kind of treatment and that it would be cost effective because the burden is so high and the effects are so devastating. So anyway, just a little takeaway. Buprenorphine is first line for opioid use disorder, for opioid maintenance treatment, and that's newer. Methadone has been around since the 1960s. Oh yeah, I was going to say at the beginning too, substance use disorders are a place where there is a massive gap between between the evidence that we have and what is in practice, right? So, you know, I mean, the first paper on methadone maintenance for opioid use disorder, anyone care to guess what year that came out? Guess the decade. 1963, right? So it's over, well, 55 years old this year. Okay, newer novel treatments, slow-release oral morphine and supervised injectable opioid agonist treatment. Yes, prescription heroin. It's actually very effective, and we should do more of it. It's actually, but it's also much more costly, unfortunately. Okay. Buprenorphine, it's a very forgiving medication. You know, I heard a comment about, oh, I don't know about prescribing this liraglutide. You know, there's a lot of people are very uncomfortable in prescribing buprenorphine, and yet you guys prescribe hydromorphone all over the place, right? There seems to be no kind of hesitation to prescribe hydromorphone, but buprenorphine, oh my God, that's kind of weird and scary. It's not really, it's very simple. It's because, well, I'll tell you why. And no one needs a special license to prescribe buprenorphine, right? So the secret of buprenorphine, it has got super high receptor affinity, but lower intrinsic activity at the new receptor. So that actually gives it some of its protective effect against overdose. It's a kappa antagonist, which I find is interesting. There's some interesting speculation that the kappa antagonism actually could have antidepressant effects, and that's being studied right now. Precipitated withdrawal, it will basically, if an opioid's on board, it will go in, knock off all those other opioids because of the higher affinity, but with lower intrinsic activity, it'll actually sort of feel like relative withdrawal to that person. So that's called precipitated withdrawal. So that is what makes it a little bit trickier to start buprenorphine. But I mean, when you keep that basic principle in mind, it's easy for me to say. You can't swallow the tablet; it has to be sublingual. When you order Suboxone, right, or in the US there are generics, well in Canada there are generics too. In Canada, all the products are combined with naloxone, so that what do people with opioid use disorder like to do? They like to grind up their tablets and inject them. That is kind of a thing that they have kind of figured out how to do. When you take a buprenorphine naloxone tablet, grind it up and inject it, the thing that hits you first is the naloxone. That's aversive. You can get the monoproduct in the US, actually, and that is, if you look at the RADAR's drug surveillance data, the rate of misuse of that product is higher than with the combination product. So yeah, buprenorphine can also raise LFTs. In practice, those of us who prescribe buprenorphine in practice, we want to capture people in treatment. We start buprenorphine. I don't worry that much about LFTs. I mean, treat first, do the LFTs later is sort of, if you care to, that's sort of the bottom line. Oh yeah, if it's Friday night or Sunday afternoon and you're on call and someone comes in on methadone and you don't know what to do, so this resource is available to you. Go to cpso.on.ca, Clinical Practice Guideline. It's basically got all the information about prescribing methadone that you need to know. You guys are all allowed to prescribe methadone for someone who comes in who's on MMT. You can continue those orders. And if you have any questions about it on a Sunday afternoon when the substance use team is not available, you can look here. And the secret is always call the patient's pharmacy. They know everything. Really, they do, and they're open on Sundays. Okay, very briefly, the last 2 or 3 minutes, resources. There's this new concept in the last 3 or 4 years of RAAM clinics, rapid access addiction medicine clinics. The Royal, you probably have heard about, they are taking alcohol patients, and they also see opioid patients. In my clinic where I work, we have also now opened walk-in hours, so if you come in Monday to Friday in the early afternoon and you want Suboxone, you will be started on Suboxone on demand. That is what we need to do. If you have a patient, this is outpatient, we always appreciate a little fax. So this or the Royal, whatever you want to do. So access to treatment. Royal, they have a fantastic service. I really want to promote that. They're lovely. E-consult, I get a lot of e-consults. Anyone who's using e-consult? Okay, so I mean, I am both a consultant and a consulter. And so, it's a way to get an answer. I mean, I will answer your questions on eConsult if you put one in. Metafee. This is the kind of the movement. It's almost a social movement. It was a study funded by AUDIT. Big gap between evidence and practice. No pharmacy, no industry funding at all, and now they've created a lot of resources for practice. They sort of launched the RAAM clinics. You go to medify.ca and there are tools, information, booklet on treating alcohol use disorder, information on treating opioid use disorder, really simple language. It's all there for you. And lastly, I'd like to introduce you to this the substance use program at TOH that we, well, actually for the past year, it's been kind of one of the best kept secrets. We are, there is a small, a tiny team, and we have dreams to grow, but we will do substance use consults for you and your inpatients. And we will recommend, we will help out. We'll start methadone or Suboxone in hospital. We can start buprenorphine even if they're on traditional opioid agonists, because the new hot thing in buprenorphine treatment is microdosing inductions, where there's no withdrawal involved at all. That's some, very small case series introduced that concept, and now pretty much everyone's doing it. We will help liaise to the community. So the way to reach us is to we could be paged through locating, or you can send an email to substanceuse@toh.ca. And that is the end of my presentation. Thanks for your attention.